more about this webinar. It started in April 2008 as a simple conference call designed for our GrandCare dealers and industry enthusiasts to get together, learn about available technologies, learn about the industry as a whole, and it sort of morphed into this industry-wide webinar where we would learn from each other and help build the brand new category. And from this webinar, we actually built the we built the Aging Technology Alliance when Peter Radsliff from Presto was speaking on one of these calls. I believe it was in 2010, or actually 2009, I think it was, and he started to talk about the idea of co-opetition and learning from each other, and from that, we grew into the Aging Technology Alliance from this call. So that's kind of an exciting little tidbit, but that's really been the designation of this webinar from the beginning, is to learn from each other and grow from each other. So with that, I mean, it kind of makes sense that today's sponsor is agetech, the Aging Technology Alliance. Now, agetech is a nonprofit member company organization that is dedicated to bringing people together who actually create the innovative products, who sell the innovative products, who provide services, who are analysts in the industry. Anyone that's interested in the aging technology industry or has some sort of stake in the aging technology industry should consider joining agetech. It's a great opportunity to learn from each other, to network with each other. We have a lot of cross-promotional events that we do. In fact, at the Consumer Electronics Show that we were just at in Vegas, which was a fantastic show for GrandCare and for the Aging Technology Alliance, we actually had a couple of agetech meetups, and we had the Aging Technology Alliance annual meeting and mixer, and it was phenomenal. We had 100 people that signed up to come to the agetech mixer, which was at the CES show floor. We got a ton of new members, lots of big players that are now joining in the agetech Alliance, including the National Alliance for Caregiving, AARP. We've got tons of interest from the people all around the industry, and if you're not aware, within this industry, a lot of big players are taking notice and getting involved. AT&T, Verizon, Qualcomm, and United Health Group, Humana. Lots of different organizations throughout this industry are seeing and noticing that there is a phenomenal need for technology in the aging industry. And, of course, with the latest Medicare reimbursement, the new healthcare reform laws that are taking place right now, where if a person is discharged from the hospital and they're readmitted within 30 days, Medicare is not going to reimburse that. Well, of course, you can see how technology has got to play a big role in that. And right now, a lot of people, insurance companies, hospitals, home care providers, everyone sort of just trying to figure out where everybody comes into play. How do we do this? What do we need to do in order to successfully implement the technology? Are there going to be new jobs created for that? So it's all a very interesting kind of market that we're in right now. It's an interesting time to be in the market. It's very exciting, and that's why it's so timely that Tim is going to be talking about this today. With that, without further ado, I would like to actually see if we can make an introduction to Tim here and get him on board. And again, if I can please ask you to share your information, share your company information under chat, who you are, where you're from, and a little bit about how you got into this industry. It would be very interesting to the other. We've got about 50 attendees, both through the phone and on the webinar today. So it would be very interesting to everybody to listen to a little bit more about you. So with that, I'd like to introduce Tim. Now, Tim is going to be talking about adapting healthcare reform and technologies to put your agency in the driver's seat as your world changes. Now, when hospitals began to select post-acute partners they can trust to lower their readmission rates, they will look for home care agencies that can monitor patients between visits, improve medication compliance, reduce falls, communicate with family caregivers, and submit regular readmissions reports based on reliable data. Based on Tim's 18 years in home care technology, consultant and writer Tim Rowan will explain the systems you will need to deploy to thrive in the very different reimbursement world that starts later this year. Avoidable hospital readmissions will be the topic of 2012, more important than winning referrals. Hospitals will look to teams of post-acute care providers to form partnerships in the effort to curb readmissions. They will not rely on home health care providers alone. Home health care providers invited to participate on these post-acute teams will be the ones with proven rehospitalization track records and with the latest remote patient monitoring technologies. Now, a little bit about Tim. He's been the editor of Home Care's premier technology news and analysis newsletter, now known as the Home Care Technology Report, since 1998. In this position, Tim has had the opportunity to keep an eye on the leading edge of healthcare technology innovation and to develop insights into the strengths and weaknesses of the companies that provide software and other technologies to home care providers. And I had the great opportunity to meet Tim at the agetech conference, not Aging Technology Alliance, but agetech with the CH. That's the CASA from California, agetech. And I got to hear him speak, and I thought, wow, he was just such a fantastic speaker and had so many innovative thoughts on this whole issue that I thought we would bring him on board. So we're very lucky to have Tim speaking with us today. And I'm going to go ahead and pass the torch over to you, Tim, if you want to go ahead and take over.
Thank you very much, Lauren. Good morning, everyone. Or I should say good afternoon, everyone, except for those of you in California. Good morning to you. I am happy to be here, and as she said, we did have a chance to meet. What was it, November, I think, in California. And I'm very excited about the work that agetech and GrandCare are doing and happy to be a part of it. Going to spend several minutes with you today trying to offer you the insights that I have gained over the last couple of years. I've been in home care for 18 years, but it seems that recently the topic has turned. The topic has refocused to the relationships that home care needs to be developing with acute care centers and with other post-acute care providers. As you know, what's going on in Washington is almost impossible to understand with the polarization among the lawmakers. We don't know what's going to happen next. But what we can be sure of is that all sides, all lawmakers, state and local and national, are going to be interested in making sure that the Medicare Trust Fund and the Medicaid budget doesn't completely run out of money in our lifetime. So there are going to be cuts, and there are going to be ways to try to save money. And the one that they're focused on right now is the dismal record that hospitals have in keeping people out after discharge. So they're encouraging hospitals right now to do something about that. Hospitals have not been able to do that, and therefore Medicare has not been able to save the money it has wanted to save by reducing the readmission rate. And so Medicare has decided if it can't save the money that it's paying to hospitals, it's just going to get that money back by fining the hospitals. And so I'm sure that everybody is aware of how that's going to work. Starting next October in fiscal 2013, hospitals are going to be hit with a 1% penalty if they don't improve, and the year after that 2%, and the year after that 3%. And pretty soon we're talking about real money. And so the hospitals now have motivation, and I believe that they will eventually turn to post-acute care for help. And home care needs to be standing there in their face saying, choose me, in order to get any kind of attention at all, because the voices of long-term care and assisted living and rehab hospitals are going to be even louder. So that's the setting in which I want to talk to you about how your world is changing. With one caveat, there's some danger here. I'll talk about that first. CMS, Medicare, is literally unhappy about the number of Medicare-certified home care agencies they have to deal with. Let's take a look at where we're at. Closing in on 12,000 of you, 12,000 certified home health providers. Probably an equal or larger number of non-certified providers offering private duty care. And I want to include that group in the discussion today. But let's first look at the motivation that CMS has to do something about what they consider a problem. 12,000 of them, but that's not all. Let's look a little bit deeper into this. Let's find out who these people are. First of all, more than half, about 6,500 of them, are agencies that would be considered small businesses by any measure, grossing $2 million or less per year. That might be surprising to you, but that's not all. 5,500 of them, and this data was up to date as recently as last May. 5,500 of them are extremely small, grossing $1 million or less. Now that's gross revenue from Medicare. I had somebody joking with me one time when I learned this information. You should call these employment agencies, because literally the purpose for their existence, their raison d'etre, their reason for being in existence, is to provide a job for usually about 4 people. And those 4 people are all in the same family. So you got a nurse, you got an accountant, and you got an owner, and maybe you've got a therapist or an aide. That is not to be critical. Don't get me wrong. Some of these tiny organizations provide the best care you can get anywhere. But that doesn't matter to CMS. They don't want to deal with 12,000 people. They would be very happy if all they had to do is deal with about half that many. And all the evidence you need to understand how the federal government, how Health and Human Services, how CMS looks at the home care industry is to look back about 15 years and see what they thought of us then. If I had you in an auditorium as a live audience, I'd ask you to raise your hands right now. How many of you were around in the mid to late 90s when CMS instituted the interim payment system? We lost, about 2,000 to 2,500 agencies during that time. And CMS didn't apologize and didn't complain about that at all. Well, here we have grown from those dark days. PPS has been good to us, and here we are back at about 12,000 and growing. A number of states have moratoriums on certifying new applications. I've kind of picked this number 6,000 out of the air, but I'm certain that CMS would be happy to deal with half as many certified agencies as they're dealing with now. For one thing, they would know that more or less the same number of clinicians would be employed and the same number of patients would be served if there were 6,000 agencies instead of 12. So they're not concerned about how many of you stay in business. They're only concerned about the beneficiaries being served. They're not going to tolerate this growth, especially some of you in Texas, the growth that has been uncontrolled lately there and in Florida and in California. They're not going to put up with that much longer. They're going to find ways to change the scenario. And the Patient Protection and Affordable Care Act that was passed by Congress and signed by the President in 2010 is one of the tools that they're going to be using. It gives them some tools such as fraud abatement. First of all, they're going to go after the bad guys that are giving our industry a bad name. There was just one last week. I wrote a story for my newsletter, Home Care Technology Report, this week that just went out today about a woman who confessed to a $200 million Medicare fraud scheme in South Florida. We thought they had South Florida under control, but apparently not. They are going to use the recovery audit contractors and others to control inadvertent overpayments. In fact, the news just this week is that many of the fiscal intermediaries and the MACs are converting to prepayment reviews of OASIS and of clinical notes. So they're not even waiting they're until they pay you anymore. They're getting rid of this, what they've been criticized for, the pay and then chase method. They're actually, and Palmetto has been the one that has started the ball rolling. They've been unusually aggressive just in recent months, denying payments between paying the wrap and paying the final claim, whereas they used to just come in afterwards and ask you for your money back. Small agencies are going to be hit hard by this. How long can you go if they ask for 40 charts and say, we'll get around to deciding if we're going to pay you for these after we've looked at them, instead of giving you the money first and looking at them later. I mentioned already the moratorium on awarding new certificates. You've seen how this has happened. They've allocated the time of their auditors, the state auditors, into 3 tiers. Well, the tier with the least priority is the tier for certifying new applicants. And they never get through. They're so busy, they never get through Tier 1, much less Tier 2 and 3. So it's not like they've said, we're not going to certify new applicants, but we're just never going to get around to it because they're the lowest priority. The only people getting certified are the ones that are going private, going to JCO and CHAP. And then what we need to be closely looking at and preparing for is the payment system that will succeed PPS. And there have been a lot of rumors, and I've got some ideas on what it might look like. Some of the pruning that the Affordable Care Act has given CMS has already begun. Take a look at what they've done. Actually, there's one missing from this list. Do I have a pointer here? Yeah, I have a pointer. There's one missing from this list. It's AmeriCare, American Family. I'll have to look it up. I'm not sure, but there were 4 large agencies called in front of a Senate investigation committee. The Senate just recently put out a 670-page report that included internal company emails wherein it appeared that they were encouraging their people to do more therapy visits to increase revenue. I don't know how they got a hold of those emails, but these 4 are in big trouble right now, and there won't be the last ones. So just one casual warning. Anybody that has used the change a couple of years ago in the therapy thresholds, and you used to have a lot of 10 and 11 visit episodes, and now suddenly you have a lot of 14 and 15 visit episodes, the government has already looked at your data and identified who you are. So be prepared. If you are the kind of agency that determines the number of therapy visits entirely based on patient need, regardless of payment, you can prove that, you should be okay. But they're going to become very, very aggressive about it, as they've already demonstrated. And the payers are going to participate in pruning, getting rid of some of the 12,000 agencies too. We've already seen the fiscal intermediary starting to deny payments at a higher rate. The ZPICs are going to come in and examine your charts, and if they find that you have a 5% denial rate after they've looked at 20 or 30 charts, they're going to extrapolate that 5% across your entire list of charts for the whole year. They're going to just multiply that penalty. The MACs are doing the same thing with increased audit activity. The recovery audit contractors still have not paid much attention to home care, and even in hospitals, they haven't recovered as much money as was predicted. So I have a feeling that that experiment is not going to last much longer. And then, as I mentioned, what comes next after PPS? What are we looking for? Last year, there were a whole bunch of examples of the way that they are cracking down. So another way to get rid of agencies is to get rid of the criminals. And here's the problem that you need to be looking for. Since you're not a criminal, they don't care. These auditors, if they find errors, if they find honest mistakes that look like they are patterns of poor clinical documentation, they will put you in the criminal category, and they'll do everything they can to penalize you and shut you down. So you might not be stealing $150 million from the government, but the MACs and the ZPICs are looking very carefully these days at your documentation. And if you don't keep constantly training your clinicians, you're going to look to them like you're attempting fraud even when you're not. And penalties are the same. They don't care what your intention is. If you're a criminal or if you're merely sloppy, they will find you, and they will find you soon. There have been a lot of agencies shut down already in Miami, Houston, LA, Detroit, Baton Rouge, Tampa, and Brooklyn. The 36-month rule you're probably familiar with, but they have all of these new tools, some of which I've mentioned already, to slow down the growth of new agencies. They don't want to go from 12,000 to 13,000. They very much want to get down under 10 again, 6 if they possibly can. So the only other thing to look at then is, what do you think is coming after they find a better payment system to PPS? It's going to have something to do with decreasing hospital readmissions. It's going to have something to do with bundling payments, accountable care organizations, and it's going to have a lot to do with encouraging acute and post-acute care providers to coordinate with each other, to improve the transition of patients from one care location to another. I don't know exactly how that payment system will look, but it will include those components. So, all I can tell you is you better be ready. If you liked IPS, if you're around in the 90s and you saw 2,500 agencies close their doors, you're going to love what comes next. The movement, the sincere attempt on the part of CMS to go from 12,000 to who knows how few Medicare certified agencies. And I think 2016 is an exaggeration. I think it's going to happen sooner than that. So, let's take a look at what the payment system might appear to be if you bundled payments into accountable care organizations. And what could be a better model for a home care agency going to a hospital administrator and saying, please give me some of your patients and share some of the money that CMS gave you, please? What could be a better model than Jimmy Stewart in It's a Wonderful Life begging for money from the big banker in town? Keep that image in mind as we go forward. I've already talked to you about what the hospitals are facing, severe penalties, and because of that, they are going to be looking for assistance in their effort to reduce the rate of 30-day readmissions. Keep in mind, we need to use the word avoidable. Avoidable 30-day readmissions. They're not going to be penalized if somebody is discharged after a heart bypass operation and they come back in with hit by a bus or with some new diabetes diagnosis. Avoidable readmissions are the ones that they're going to focus on, and these hospitals are scared to death. If you take a look at the upcoming HIMSS annual meeting schedule of educational events, you know HIMSS, of course. It's the hospital IT people, the Healthcare Information and Management System Society. They draw about 30,000 people to their annual convention. They're meeting next month in Las Vegas, and almost every educational event talks about readmissions, avoidable readmissions. So, where are they going to turn for help? To answer that question, I'm going to start with bad news. Once again, if you see my January 18th issue of Home Care Technology Report, my lead story is about a major study conducted by the Dartmouth Atlas for Healthcare organization, authored by several physicians. They talk all about how poorly hospitals have done, especially they studied from 2003 to 2009, how poorly they've done in reducing their readmission rate, and wonders, what are they going to do now that they're going to be penalized? It doesn't even mention home care. In fact, when this report identifies where patients were discharged, it talks about the percentage that went to long-term care, the percentage that went to rehab hospitals, and the percentage that went home. And it doesn't even bother to further break down the people that went home alone or the people that went home with skilled nursing from home care. It doesn't recognize that home care makes any difference in the readmission rate when people are discharged to home. And this is a major study by some very smart people. I think that's your fault. I think that hospitals don't know how important you are because we haven't told them. We haven't gotten in the face of the hospital administrators and said, look what we can do. We can prove it. And that's going to have to change, because if it doesn't, they're going to go to the long-term care as their solution to their readmission dilemma. So, first of all, is it true? Can you help? Do you know your recent home health compare scores for hospital readmission? Have you recorded the readmission prevention measures that you put in place? Have you written stories about them for your local papers? Have you put together white papers about the successes that you've experienced so that you can hand those someday to hospital administrators? Do you have a list of the technologies that you're using to monitor patients when they're in their home when the clinician is not there? And you have studies of your own results and how you have reduced your own readmission rate so that you can lay that in front of the hospital? Have you gathered your own evidence internally with your agency that can show these hospitals your track record? So first of all, do you have a good track record? Second of all, is it visible? Can anybody tell that you're any good? Have you published papers? Have you tracked your results? Have you written down, have you studied the readmission rate that you had before you brought in telehealth and the rate you had after? Have you studied that? Is it any good? Does it show progress? If it's apparent that you're good at this, if it's apparent that you do have something to offer to hospitals, then the next step, obviously, is to retrain your sales and marketing people. No longer do they go to docs and hospitals and say, please give us some referrals. No longer do they knock on the door of the hospital discharge planner and say, hey, we're really good. You should send us a few of your patients. From now on, you need to go to the people that are going to be hurt by the Medicare penalties. For example, the finance people, maybe even the CFO. And you need to have your salespeople sit down with them and say, I can save you money. Give your patients to my network of care, and I will make sure that you don't get hit with the penalties. I can do this for you. It's a whole new orientation for your entire sales staff. Here's the third step. Remember, first step is, are you any good? Second step is it apparent that you're any good? Third step is, you probably can't do it alone. I'm going to talk to you about a city where I've seen tremendous success putting together a team of these kinds of post-acute care providers that you see listed here. In the interest of time, I'll let you read them rather than read them to you. And this is how it will look. You're going to put a care coordinator, a transition manager, a case manager, whatever you want to call it, in the middle of the patient experience. And that case manager is going to be responsible for that patient no matter where that patient goes after the hospital. That case manager is going to make sure that at all times that patient is in the least costly location for which they are appropriate. That case manager might be employed by the home care agency in the team, in the network. It might be employed by the rehab hospital within the network. It might be employed by the network where they pool their money to hire a person or two. Doesn't matter. Doesn't matter who employs the case manager. That case manager is loyal to the network, not to the specific employer within the network. Okay, you've created a post-acute team. You've learned to move the patient wherever the patient needs to be. Obviously, the home is always the least expensive. Patients might not be eligible, might not be safe at home, so you might have to go somewhere else first. Case manager is empowered to make that decision. And all you have to tell the hospital CFO is, don't worry about the care location. We'll worry about that. All you need to know is they're not coming back, we promise. And I'm going to give you an example. This is not just theory. This is working. So, before I get into the specifics of a location where this post-acute care network is actually creating astounding readmission improvements, maybe this would be a good time to take a look at some of the questions that have been coming in. What do you think, Laura? Ashley? First, I see a question from Kristen Bayer that says, what do hospitals think is the cause of avoidable readmissions? You know what? I would be the last one who would ever claim to understand how hospitals think. Let me start with what I think. I think the primary cause is lengths of stay that are too short. You know, the hospitals get their payment from Medicare on day one. Once the patient is stable, as you well know, they get them out of there as quickly as they can, especially if it's Friday afternoon, right? I have not seen specific studies about this. I think that that hospitals are studying it. But if you look at the Dartmouth study that says that hospitals made no progress whatsoever from the time span of mid-03 to mid-09, my guess is the hospitals have no idea what causes it.
Well, and I think that, I think that in addition to that, I think that there are certain things that the hospitals realize that they can't fully prepare people to be discharged or transitioned at this point. You know, they recognize that the common reasons for hospital readmissions are, you know, that somebody is not supervised at home, and the hospital really has no way to technically do that. Although with the latest reimbursement changes, they're going to have to find a way to make some partnerships and with home care providers or geriatric care managers or some sort of care transition coordinator that is going to help with the supervision. The medication compliance is a leading cause of readmissions. The lack of knowing what red flag symptoms are is a leading cause of readmissions. You know, things like that, and lack of resources. So I think you know, the hospitals may have an idea of what these causes are, but I don't think that they have the resources themselves to actually do anything about it, except to develop new programs. But legislation is forcing them to figure out what to do because they're going to be left holding the bag.
Yeah, the penalties are going to force them, but you're absolutely right. The sequence that I have seen, and everybody in home care knows that falls are one of the major causes. But that's a symptom. There's a cause for falls, and it's usually medication noncompliance. But in many, many, many cases, that is also a symptom. You've got to go behind it. What is the cause of medication noncompliance? In too many instances, it's finances. People are either cutting their pills in half, they're taking them every other time they're supposed to take them, or they're not even getting the prescription filled at all because they can't afford it. And if they're non-compliant with their medications and they have no home health nurse to guide them and encourage them and a home health social worker to help them find a solution to the financial problem, they're going to land right back into the hospital. And the part that mystifies me is that the hospitals have not increased their referrals to home care once they've learned that, once they've seen that as a problem. They know that putting a home care nurse in the door is going to solve the medication noncompliance problem. But they have not acted on that. So I have to admit that I'm somewhat mystified about the way hospitals think. I'll give you one more example. In this Dartmouth Atlas study that I was mentioning before, one of their suggestions to reduce avoidable readmissions is to produce better instructional handouts to give to the patients on their way out the door. Sometimes, yes, I'm just baffled. Let me get through a couple more questions real quickly. Kristen, your second question, are you aware of evidence that already exists, track records for the value of home health care? I'm going to talk about one of them as an anecdotal evidence, but the other one, of course, that you have to look at is the report conducted by Fazzi Associates and funded by Delta Health Technologies. It's available. You can download the report for free. Delta has paid for it. And if you're not sure how to find it, I'm going to send you back to my newsletter again, homecaretechreport.com. Look for Delta's ad and click on the ad. It'll take you right to the place where you can download the report. One more, which will have a greater impact on the hospital's finances? A, the loss of revenue from all of the current readmissions, or B, the 1% penalty? Art, the answer to that is both, because in addition to the 1% penalty, CMS is finally going to more aggressively enforce the rule about not paying anything at all for the second admission within 30 days. The hospital will get no new payment if they accept that patient, if they readmit that patient within 30 days. So I would say the answer is A, the loss of revenue from the current readmissions, whether they readmit them or not, is going to hurt them. The 1% penalty will be a lot of money for the larger hospitals that have a huge dependence on Medicare for their revenue. But I think if you have to look at it two ways, that readmission on day 25 or 29 is no longer a revenue source for the hospital. They have to pay for that out of the original payment they got. So I think both of those hits are going to be pretty heavy. Kristen, I think I can answer your next question as I go through this anecdote, but let me read it. Do you anticipate liability problems? Will the hospitals come after home care in cases where there is a so-called avoidable readmission? It depends on how much you promise, and it depends on any contract that you might have. I have heard of a program that home care agencies can adopt, which will allow them to confidently go to a hospital and guarantee that that patient won't come back within 30 days. If an occasional patient does, if they fail on the guarantee once in a great while, there may be a financial arrangement that they've pre-agreed on with the hospital, but there's no set dollar amount that the hospital will be able to come after the home care agency. Take a look at it this way. If the hospital readmission rate is 20%, which is typical right now, and you walk in the door with your post-acute care network and you reduce it to 10%, you've saved them millions of dollars. So just because you don't reduce it to zero doesn't mean that they're going to come after you and say, hey, you weren't perfect, so therefore we're going to come after you. I think the idea of reducing it where they have been unable to do so is going to save them so much money, they won't care about your occasional miss. Scott Landau, I'm not sure what your question means. Who is paying for this education? Is that a part of Medicare reimbursement?
I think he might mean like who's paying to help make it happen, I guess, to successfully use some sort of to train people how to transition people. Like who's going to train the care coordination people, the new employment positions that are going to be in place. I mean, so as far as there might be a new role for somebody who's going to actually coordinate the care between the hospital and the home, which previously the discharge planner was just sort of making sure you've got a ramp, you've got this, you've got home care, but after that they were sort of out of the loop. So who's going to be that new person and who's going to train those people is how I took it. But maybe, Scott, if you want to just write a little bit more if I'm off base on that.
Yeah, Scott, feel free to elaborate on your question, but if I understand you correctly, there is no money for education to create these new post-acute care networks other than grants. Let me answer that by talking about the example that I've got coming up. If it's all right with you, there's a bunch of questions, but I want to make sure I have time to get through this. So I'm going to pick up where I left off with Scott's question and Gaitha's question and Dan's question as soon as I finish this section, if that's all right with you. I want to introduce you to the Community Health Initiative Network, which is located in Las Vegas. Their policy is they have gone to the hospitals, they give us your sickest patients, your oldest patients, the ones that are most likely to be readmitted. They ask the patient to sign up for this program voluntarily, and if the patient opts in, they send a care coordinator into the hospital a day before discharge, maybe even 2 days. They do several things. They evaluate the patient for the appropriateness of remote patient monitoring systems, whether that be home telehealth or phone calls, mere phone calls, or anything in between, including motion detectors and all the sophisticated smart home technologies. They decide what's going to go in. They bring, if it's going to be a home telehealth monitor, they bring it into the hospital and begin to train the patient how to use it before discharge. Then you have this care coordinator who decides the first care location and consults with the patient about their preferences, and then continually keeps up with the patient as time goes on to make sure they are always in the appropriate place. That's the offer that this network makes to the hospitals. At the moment, there is no funding whatsoever for the network itself. There's been a grant applied for, and I'm kind of waiting right now to find out if the network has received it. It's imminent. So right now, these case managers, called care coordinators, are employed as they have always been employed by the same post-acute care provider that belongs to the network. Belonging to the network is optional also. There are several home care agencies, several SNFs, several assisted living, several rehab hospitals. Some home care agencies have opted in and then decided that it wasn't making them rich, so they got out and don't belong anymore. So membership is voluntary by the post-acute provider and by the patient. So the care coordinator is instructed, if you want to be part of this network, you as a case manager will first be loyal to the patient. Whatever is best for the patient is your first priority. Secondly, where is the least expensive location of care, because your second loyalty is to the payer. And then only third are they loyal to their own employer or to the other providers in the network. And everyone who belongs agrees to that hierarchy. Even though the hospitals are only penalized for 30-day readmissions, this network tracks patients for 90 days. They make sure the patients get to their doctor appointments. They make sure the patients are following their diet. They do this with phone calls and visits and in a variety of ways. They make sure they're medication compliant, and they make sure that social workers teach them about all the services that might be available to them. They don't leave them alone, in other words, to find those services themselves. The way this began, the originator, the founder of this network, went to one hospital group. There were 5 hospitals in that group, and they were skeptical. They said, all right, we will let you try it with one hospital. Within the first 90 days, when they were taking the sickest patients and not one was readmitted, the hospital came back to the network and said, please sign up the other 4 hospitals in our network. Today, 12 of 13 hospitals in Las Vegas are participating. And there was no sales job involved. The hospitals begged to be admitted. In the first 90 days of this network's existence, there was one hospital admission for an inpatient procedure that was totally unrelated to all of that patient's other conditions. So there were 0 avoidable admissions. Today their rate is at 5%. They've been doing it for a year. They've brought the readmission rate from 20% to 5%, and keep in mind this is 90 days. Now, here's a good answer to Scott's question. I'm not sure the hospitals are happy about keeping them out from day 31 on, but this is what's been happening. The payer's very happy. Medicare is very happy not to keep these patients out for 90 days and longer. I'm not sure how the hospital feels about it, but they've saved so much money on the 30-day readmissions that they don't really care about the lack of readmissions for the next 60 days after that. How do you create something like this in your neighborhood? First of all, you got to look around town. Do you have people that might be willing to cooperate with you? Do you have competition? Are your competitors better at keeping people out of the hospital than you are? Are your competitors using home telehealth and other remote patient monitoring systems? Are they using the telephone strategically to keep track of how patients are doing? Do you know your competitors' home health compare rates with regard to rehospitalization? Do you know if they have already been to one of my speeches and have already learned what you're learning today? So look around town, find out. Do you have cooperators or do you have competitors around town? What about people outside of home care? Are you familiar with the people that own the long-term care facilities? Do you invite to lunch once in a while the people that operate assisted living and rehab hospitals and the like? If you were to have a meeting and get all these people together, would you be able to put together a partnership of all of these people? Would they be interested in cooperating? So it starts with, do you even know who they are? There's several places in the country where this Las Vegas model is being duplicated, and from everything I've heard, it's working and working well. So let me get back to your questions, but first just summarize very quickly. Like it or not, your world is changing, and if you want to survive, you have to change and adapt to it. The wind is changing, and you've got to reset your sails. If you want to keep your business open, you don't have any choice. Your survival depends on it. So change your salespeople's thinking from begging for referrals to developing partnerships with hospitals, and change your attitude from one of competing with other post-acute providers to get more referrals than they do to cooperating with them. The reason for this is because of the Affordable Care Act, health care reform. The Department of Health and Human Services is going to step up its interest in centering everything around the needs of the patient. They are going to care less and less about your business surviving and more on the U.S. healthcare system itself surviving, the Medicare Trust Fund surviving. Remember that we have until October of this year before the penalties start to kick in. You only have a few months, and it's going to take you that much time to get ready. So don't plan this for February 1. Plan it for today. Get started. This is the way you can contact me. My newsletter, as I mentioned, is easily found at homecaretechreport.com. I invite you to email me at any time if you'd like to go over this in detail. And now, how much time do we have to get to some of these questions? What do you think?
Oh, well, we can probably run about 5 minutes over, so that's okay, and people can log off if they need to. But we'll,
All right.
If we can't get to all the questions, we will absolutely be posting this recording on our blog, and if you wouldn't mind, Tim, answering some of the other questions, I can just simply post the answers after, and we can direct people there.
Yeah, I would be happy to hear from people later. Just very, very briefly, in addition to the newsletter, my work includes in-person consulting for technology vendor selection if people have shopping projects that they need help with. I also have an online version of that that's free. It's homecaretechnology.info, where you can start your project, start your due diligence to look at the features and functions various vendors offer. So contact me. I'll tell you about all the different things that I do.
And I wanted to also break in to say that the next webinar that we're having is actually on Groundhog's Day, February 2nd, and actually Jeff McCalca from AARP is going to speak on the overview of AARP's Innovation 50-Plus program, and he's the Senior Strategic Advisor for Thought Leadership at AARP. He'll be talking about their Innovation 50-Plus program. So that's our next webinar is on February 2nd. And we are still seeking a sponsor for that webinar, by the way. So just wanted to throw that in there. So contact us, info@grandcare.com, if you're interested in sponsoring that webinar, in which you will be given some time to speak about your organization.
Okay, Scott Londo, I love your imagery. It's not surprising that when the government regulates healthcare, just like war, we have no exit strategy. I think that providing patient discharge education a day before discharge is a huge improvement over the current hospital practice, which in my experience, and I've had a lot, my parents are 87 and almost 92, I've watched this happen. These people are discharged to the curb. They walk you out the door in the wheelchair, they help you into the car, and they wave goodbye. Anything is better than that. So patient education prior to discharge is a huge improvement. Yeah, maybe someday we can get your model, Scott, and start doing patient education at the beginning of treatment. But I think home care and long-term care and all the other post-acute folks have a lot less influence in the hospital early in the admission stay than they do toward the end. Gaitha, when GrandCare, the technology provider, goes to the home health provider who is keeping a client from readmitting, will CMS be reimbursing the home health organization for technology or just for services? Will the home health organization get any reimbursement from the hospital? I didn't go into detail about accountable care organizations and payment bundling, but one of the plans to succeed PPS is that a patient will be given a lump sum when they enter the hospital. And the hospital will share some of that money with the post-acute care community. So the answer is kind of yes, that the home care agency will perhaps be able to negotiate an arrangement with the hospital that they get more the longer they keep them out from being readmitted. But there's a side note here. If you have contracts with insurance plans, they are getting more and more savvy to the value of paying you to prevent readmissions. Insurance plans are much more likely to reward you than Medicare is if you make arrangements with them. Kind of have to talk them into it, though. Let's see. Is the loss to the hospital of 3% really that costly if one considers the overall lower total number of admissions they have and the resulting empty beds? Well, I think I answered that before. Yeah, 3% is huge. If you consider the millions and millions of dollars these hospitals get every year, it's 3% of their annual total Medicare payments. So Medicare comes back at the end of the year and says, all right, we gave you $100 million. We're taking 3% of that right now, all at once. That's the 3%. And as I mentioned, they're not going to get paid for these readmissions anyway if they come back within 30 days. So I don't see it as a loss. When is it better to use a physical home care nurse versus a virtual one using technology? George, this is an entire presentation. This would take an hour. It's always better to do both. It's always better to combine technology in between in-person visits. This is not an either-or situation. This is a both-and. And I think that folks at GrandCare know that better than I, and can probably explain it to you. I'm not familiar with how this is working, so I've got some questions I don't have to answer. Is that what you're saying, Laura?
Yeah. So the ones that ones
Okay.
that I feel like you've already answered, I answered verbally here. Yeah. I mean, if there's anything else that you want to add, you can add anything to any of them.
I just want to add thanks for HTG Jude Harper. Love it when anybody calls me awesome. And I want to thank everybody for spending this hour with us. And again, please feel free to contact me directly. Send me an email. I'll give you my phone number. More than happy to stay in touch and go into this in more detail with you as you learn more about it and have more questions.
All right, great. Well, thank you so much, Tim. This was so helpful and so timely. Gosh, what a great topic. And I feel like we're going to have you back for a part 2 at some point. Thank you so much for joining us today.